Obesity doesn't just raise the risk of developing cancer, it actively shapes how cancer behaves once it begins, driving its progression and undermining the body's ability to respond to treatment. This makes obesity a biological accelerator, a condition that not only helps tumors take root but also fuels their growth, adaptability, and resistance to therapy. In an era of increasingly precise cancer treatments, this hidden influence of fat tissue has become an urgent and underrecognized obstacle, one that could derail even the most advanced oncologic strategies. At the cellular level, tumors in individuals with obesity develop in an environment saturated with metabolic dysfunction, inflammation, and hormonal imbalance. This biochemical setting creates what researchers now call a pro-tumorigenic niche, a landscape in which cancer cells don't just survive but flourish. Adipose tissue, once thought of as inert energy storage, is in fact metabolically active, secreting adipokines such as leptin and resistin, as well as inflammatory mediators like TNF-A and IL-6. These molecules enhance angiogenesis, the growth of blood vessels to nourish tumors, promote cell proliferation, and protect malignant cells from immune system attack. Obesity-induced insulin resistance further complicates the picture. Elevated circulating insulin and insulin-like growth factor 1, IGF-1, are potent mitogens that stimulate oncogenic pathways like PI3K/ACT and MAPK. These pathways not only drive cancer cell division but also make tumors more aggressive and less responsive to standard therapies. In breast, colorectal, pancreatic, and endometrial cancers, among the most obesity-associated malignancies, hyperinsulinemia is directly linked to faster disease progression and poorer survival outcomes. Fat cells themselves play an unexpected and direct role in tumor progression. In breast and ovarian cancers, for example, adipocytes in the tumor microenvironment are known to feed cancer cells by releasing fatty acids that tumors then use as fuel. This process, called lipolysis-mediated metabolic reprogramming, helps support rapid tumor growth, especially in nutrient-stressed environments like those encountered during chemotherapy. In effect, the fat surrounding the tumor becomes a functional part of the tumor's support system. This lipid-driven tumor growth also has implications for treatment resistance. Studies have shown that the altered metabolism of obese cancer cells, relying more on fatty acid oxidation and less on glucose, may render them less susceptible to drugs designed to target glycolysis, a hallmark of cancer metabolism. Furthermore, tumors in obese individuals often display greater hypoxia, oxygen deficiency, another hallmark of aggressive, treatment-resistant cancers. Hypoxia is known to drive genetic instability, promote metastasis, and reduce the efficacy of radiation therapy, which depends on oxygen to generate DNA-damaging free radicals. Immunotherapy, a revolutionary tool in modern oncology, may also be compromised by obesity. While obesity can create a paradoxical increase in certain immune checkpoint molecules like PD-1, sometimes improving initial responses, this effect is not sustained. Chronic inflammation and immune dysfunction in obesity ultimately exhaust T cells and impair their ability to mount durable anti-tumor responses. Moreover, the systemic inflammation seen in obesity often mimics a tumor-promoting, immunosuppressive state that may blunt the long-term efficacy of checkpoint inhibitors and other immunotherapies. In short, fat-derived inflammation may help the cancer hide in plain sight. Clinical outcomes reflect this biology. Obese patients with cancer frequently experience lower overall survival and disease-free survival than their leaner counterparts, even after adjusting for cancer stage and treatment access. They may also face higher rates of treatment complications, such as infections, wound healing delays, and cardiovascular events during therapy. Chemotherapy dosing is another challenge. While underdosing in obese patients has historically been common due to toxicity fears, full dosing can lead to unpredictable pharmacokinetics because of altered fat muscle distribution and liver metabolism. Despite these dangers, many treatment guidelines still fail to fully account for obesity as a modifying factor in cancer progression or therapy design. Oncologic trials frequently underrepresent patients with obesity, and most preclinical cancer models use lean animals, failing to replicate the obese tumor microenvironment. This limits our ability to predict drug efficacy and develop tailored strategies for the growing majority of cancer patients who fall into overweight or obese categories. The consequences of ignoring this biology are immense. As global obesity rates soar, more patients are presenting with fat-fueled tumors, cancers that are biologically primed to resist treatment and progress more rapidly. If we continue to treat these cases as if they occur in metabolically healthy individuals, we will miss critical opportunities for intervention and risk widening survival disparities even further. Addressing this crisis requires a paradigm shift. Obesity must be treated not just as a risk factor for cancer onset, but as a dynamic and ongoing modifier of cancer biology. Cancer treatment plans should include metabolic assessments and interventions like weight loss, anti-inflammatory strategies, and insulin-sensitizing agents may need to be integrated into standard oncologic care. Precision medicine must expand its scope to include precision metabolism. Ultimately, cancer in the context of obesity is a different disease, faster, more elusive, more entrenched. Until we begin designing cancer care around that reality, the tumor will continue to draw fuel from the very body it inhabits. And the patient, surrounded by layers of biology we failed to address, will bear the burden.